primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is finally a solution that works for patients, families, doctors, and employers. We founded Zest Pediatric Network to lower the barrier for pediatricians to enter the DPC world. I am Dr. Drew Herz, and this is my DPC story.
Dr. Andrew Drew Herz, MD, is a leader in pediatric medicine with over 25 years of experience driving success in multiple aspects of healthcare. He has the perspective of a physician with private practice, healthcare executive, population health, alternative payment models, and startup endeavor experience. His consistent goal is to optimize solutions for patients, physicians, hospitals, and child-related community organizations. Drew was a first-round winner of the prestigious Centers for Medicare and Medicaid Healthcare Innovation, or CMMI Award. This $12.8 million grant helped establish one of the first pediatric Medicaid accountable care organizations in the country. Before leaving corporate medicine, Drew was Vice President, Community Women and Children's Services at University Hospitals Rainbow Babies and Children's Hospital, where he oversaw 200 general pediatric and OB-GYN providers. In 2021, Drew started Technion Health Equity, a purely pediatric healthcare consulting company. In 2022, Drew co-founded Zest Pediatric Network, the country's first concierge-style direct pediatric care network, now with 4 offices in 2 states. Dr. Herz serves as a medical advisor for many companies, including Innovaccer, CureView Medical, Now Vitals, Vital Exchange, Pedialytics, Develo, Wellio, Bent Health, and eSimplify. Thank you so much for tuning in. Find out more about DPC, including resources, discounts, my favorite tech tools, books, and more at mydpcstory.com. The mapper has been updated, so now you can look for practices by specialty. Follow us on your social media platforms at our handle at mydpcstory, and be sure to subscribe to our newsletter and, of course, the podcast feed wherever you listen to podcasts, so you won't miss when the next episode drops. With that, welcome to the podcast, Dr. Herz.
Thank you very much. I am thrilled to be on this. I've been following your podcast for a couple of years now.
I'm so glad to hear that. And I think it's going to be a fantastic conversation, especially with what you guys have built at Zest and your guys' experience coming in. Clearly, you know that getting into DPC is sometimes a barrier for people who do not want to do the entrepreneurship and who want to be able to quickly pivot from employed medicine, fee-for-service, to the direct primary care practice model. So I'm super excited about today's talk. And with that, I wanted to go back into your experience because clearly, as in your bio, you have had so many years of experience, and yet you left. And so I'm wondering if you can tell us about your days starting out as a pediatrician, how you got to the point where you were experiencing all of the things, and what happened that made you leave to do consulting.
Thanks for that question. It's a story I love to tell. I'm not going to go too much into detail, I don't think, about the good old days before the EMR and before corporate health really took over many practices, although I've always worked within a health system and had one foot in kind of a private practice model owned by a health system and the other in the hospital system, first as a hospitalist, then as administrator. But eventually, as I went through my career, I always was starting something new. I was always advocating for the doctors to be able to better take care of their patients, always looking for solutions to help the doctors help the patients. And eventually, I wasn't able to innovate as much as I wanted to. I wasn't able to advocate as much for patients. Corporate healthcare, as everybody knows well, has changed drastically over the last 10 years. Margins have shrunk, and there's so much more emphasis on productivity, and the poor health systems can barely keep their own doors open. So I was no longer able to really advocate for patients the way I wanted to. I was no longer able to help the doctors help their patients, and I was no longer to be as innovative as I had the fortunate ability to do most of my career. So I decided to leave. It was time for a change. Didn't know what I wanted to do. So what do people do when they don't know what they want to do except not have another job in corporate health? They consult. And I was fortunate enough to help out a brand new DPC practice in town. They were the first one in the Cleveland market. They'd actually approached us when I was working at the health system and said, "Can we do this together?" And I said, "Yes, let's do it together." But they eventually, for a number of reasons, decided to do it on their own. So once I left corporate health system, they had just opened their doors. I was so proud of somebody starting something from scratch. And during the pandemic, this was about halfway through the pandemic, and I started helping them. Then they said, "We love this model. Why don't we expand it into a network?" And at first I said no. For many months, I said no. I was consulting and I was enjoying myself. I had built networks. But the more I consulted, the more I realized the direct care models are part of the solution for what ails healthcare. I'm speaking to the choir here, but especially in primary care. It's not the only solution, but it is parts of direct care model are a significant part of the solution. And so eventually I said, let's do this. Let's build a network. Let's lower the barrier for other pediatricians to enter the direct care models. And off we were. Off we went. We took a year to figure out the corporate structure of what a network had to look like. A network is very different than an individual direct care practice. And we wanted to build a network that kept what all the DPC doctors love about owning their own practice and having that individuality. So we had to create a model that allowed doctors to be individual, yet benefit from a network and lower the barrier.
I just think it's fantastic. And one of the main reasons I think it's fantastic what you've done is because it's physician-led. I mean, all over your website, you talk about that this is a physician-led network. And I think that given the state of American healthcare, and I was joking with somebody that like I was trying to become a nurse practitioner online, like literally within the last 6 months. And I'm like, cool, I can do it. Like I could be an online certified nurse practitioner, and then I can magically become a doctor in the state of California with certain requirements. I can't do that with a board certified accredited medical school. It's impossible. So I just love that this really speaks to you guys are physicians, you and the doctors, Mistovich, Dr. Keeley and Justin Mistovich created this with the understanding that they brought to the table as DPC doctors, with the understanding that you brought to the table with all of your years in advocating for physicians and consulting to and I love that you spent the time to really figure out like how this could be helpful for not only the community, but also the movement.
So thanks for bringing them up. Keeley Mistovich, they're husband and wife team. I'm the third one, which is a interesting dynamic and wonderful. I always say I work for them, but the three of us are the co-founders. And Keeley is one of the ones that started that first practice. So she had researched DPC for a long time before she had left the other practice she was with. And Justin is a pediatric orthopod. He has his MBA and has a very entrepreneurial spirit. And then I have all the experience of a network. So I always say they have full-time jobs and they're co-founders, and I'm the one that's really helping their vision come a reality. We have been very conscious of the fact that we are physician-led, and it is all over our website, because we don't want to become the man, right? We all talk about people left corporate healthcare because they didn't like working for the man, so to speak. And I was the man for a number of years. And so we are very thoughtful and conscious about not becoming the man. Our model is an MSO model, a management service organization model. So each doctor has their own LLC and then hires Zest Pediatric Network to run their practice, essentially. And so they still have their own LLCs. We work for them. It's a collaboration, obviously, and we're building a brand, but it is physician-led, and we're very conscious about not being overbearing for the physicians. They make their own decisions at a local level.
And I'm sure there's people out there who are, especially pediatricians, if they have not heard of Zest Pediatrics yet, I'm glad that they are hearing about it now, because there are definitely ways to be part of this movement. And you guys have laid out a foundation for people to maintain autonomy while being conscious, like you said, of not working for the man. I mean, we need some kind of DPC shirt that says that for sure. So now let me ask you, in terms of the name, I wanted to get into the name and your guys' trademark. You have an R symbol. I only have a TM for the podcast. You guys have an R. I mean, that's fancy stuff. But how did you go from, all right, we're talking, we're getting things off the ground, we're going to plan, we love this idea of an MSO. How did you guys come up with the name, and how did you go about trademarking it?
It's a fascinating and fun story. If you'll give me a few minutes to start from the beginning. We knew we wanted to create a network, and Zest, as we get into this, is much bigger vision than a simple DPC practice. We have a much bigger vision. We call it the Zest Pediatric ecosystem, and we can talk about that in a minute. So during that planning year, I was really trying to figure out, how are we going to bring in what I've learned about population health, what Keely was passionate about relational care and about building relationships. How are we going to make this into a model? And so we originally had a name called Thrive. And what that stood for was, it was an acronym: Teaching Healthy Relationships, THR, Inspiring Value-Based Excellence. Thrive, THRIVE. And we love this because Thrive speaks to people. It's a pediatric type phrase, and we loved it. So we applied for a trademark for that. During that process, it was disputed. We received a letter to stop using the term Thrive. It was protected by, I'll say, Kaiser Permanente. We didn't want to go up against Kaiser Permanente, who owns the word Thrive in the medical field. So we spent months coming up with Zest. We didn't want anything else that anybody was using in healthcare, and we couldn't come up with anything. So then we started making up names, and then we came up with Prospera was a finalist. Prospera is actually Spanish for thrive, and we said, we'll get around the trademark with Prospera, but everybody said it sounds like a pharmaceutical company, and we were kind of at our wits' end. And Keely just all of a sudden said Zest, and my wife said that's a soap, but a lot of people haven't heard of Zest soap. And anyhow, we went with Zest. We love the name. We knew we wanted to trademark it from the get-go. We went through that process. It takes about a year. You apply for it, and the Federal Trade Commission, or whoever it is, FTC, goes through, or the Trademark Commission, has to review it, and we got it, and we were thrilled. So we have registered trademark for Zest Pediatrics, or Zest in pediatrics, so we can use the R now, to your point. But it's a fun story.
It is. And it's definitely words of wisdom also for the listeners, because if you have not trademarked your practice, I have trademarked Big Trees Health, and we are Big Trees MD, run by Big Trees Health, because that was not claimed at the time. And the same thing could be for your practice going into the future. If you're in a different state, you're opening up your own practice, or you're planning to open up your own practice, trademarking is a thing. Now, there's DIY ways to do it, and then there's also ways to hire a legal team to help with that, definitely depending on your preference. And also, just to put a note here, if you're also thinking about opening a clinic, think about get those domains now, get your social media now, because these are the things that are going like hotcakes. Somebody made the point to me that's very true. Digital domains are real estate. So you're basically investing, $20 a year at the most per domain. And so if it's worth your investment to have that just in case, that's one of my things to encourage people to do when they're like, I want to do it, but I don't have it yet. If you don't use the domain, dump it later, but at least it's yours for now. So I love that story.
Coming up with your name.
Yep.
Search domains with the name. And that was the other challenge we had, is we wanted to do that. And we also, if you're a practice in one little small geography, you need your domain. You don't need to trademark as much. Our vision, we'll get into that, is to save pediatrics, and we want to be a national network. So we really needed to trademark our brand.
Fantastic. Now, you guys, as you're focusing on physician autonomy, as you're being the MSO for pediatricians coming into the Zest network, I want to ask about the structure, because you do have a board. And so I'm wondering, How did you guys have a board, and how is funding going into the network? Because especially with you having success as being a CMMI award winner, how did you guys get the funding and the support from financial means as well as from your board members?
When we were developing the model for Zest and what it would look like and the whole vision for it, we wanted input from other people, and mainly business people more than healthcare people. So we had several focus groups. We probably had about 20 people that we knew, and some local, some not. And so we had 2 focus groups, and they gave us great feedback, and we tweaked the model. And out of those focus groups, we had a couple people that were very engaged, and they were the ones that started as our initial board members. Right now, it's an advisory board. It will become an official board in the future, but right now it is an advisory board. Again, is what was recommended to us for many people. An advisory board is your sounding board. It's your think tank, helps you with connections, helps you with business understanding, but they don't have any governance over you, so you can still maintain your vision. We want to expand the board for expertise that we don't have yet, and that's always on our roadmap to do, is look for the right people to add diversity in all the terms of diversity, but including skill sets. As far as fundraising, we have decided to bootstrap this ourselves. We are self-funding it, and that is our plan. We spoke at our last quarterly retreat about how are we going to move for our next set of offices that we hope to open at the end of this year and in 2025. And we still made the decision that we will be self-funding and bootstrapping this endeavor. We are physician-owned, and we want to really be able to control our vision and what we're creating in our pediatric ecosystem. Getting outside funders risks losing some of that autonomy.
Yeah, 100%. And I'm sure that everybody listening who understands the autonomy that we experience in DPC is nodding their head, because that is definitely a big thing that needs to be kept at the forefront. We are going to be talking about your guys' involvement with Medicaid, which is a recent development, but people like Dr. Garrison Bliss, who started the direct primary care movement, go back and listen to his episode. I think it was maybe a July 30th episode of 2024, if you're listening in a different year, where he, Dr. Phil Eskew, and Jay Keast spoke about how the history of DPC can definitely continue as the future of DPC if it is physician-led. And even when we explore opportunities to grow like you guys have done at the network. So with that,
I'm going to go listen to that. I've not listened to that episode, so I
yeah.
will.
Absolutely. It's a good one, especially from the guy who started it all to now. It's very incredible to hear the history woven throughout. So it was the 3 of you, you're opening this network. How did you find doctors to join the Zest Pediatrics network?
Fabulous question. It was brute force. First of all, you have to remember that from locally in Northeast Ohio, I have been doing this and running peds for a large health system for a number of years, decades. So I knew most pediatricians. I had hired a lot for one system. I had interviewed a lot for people working at other systems. And through network, I just had a large pediatric network. So I reached out to people who I thought would be good candidates and told them about direct care. Teaching them about it it's a journey. Everybody loves the concept once you talk about it. People are reluctant to do it for a few reasons, and I'm happy to go public with it because it's very important for doctors to understand the concerns, and it also speaks to part of what we're doing. The hesitancy, number one, I really love my Medicaid patients, and I don't want to not be able to continue to take care of my Medicaid patients. So you know where we're going with that in the conversation. So that's part of it. Number 2 is I don't want to be on call all the time. I love being on, I love being off. We tried to explain to them that it's not onerous when you're going from 3,000 patients, and if you're covering for 5 doctors, 15,000 patients, to covering for 300. But there's people who just say, I'm on, I'm off, I'm off. I'm not mixing it. Then there's those people that say, I can't take the financial dip, right? I can't afford right now. I have mortgage, kids getting ready for college, I have private school, or I have whatever car payments, and they can't afford the financial dip, which is why we actually support a lot of side gigs and help get side gigs to help support that. We also are willing to help doctors through that financial dip. We can get back to that. And the 4th reason is I don't believe it'll work. Nothing I can do for those people. Or they'll say, I love the model, go prove to me it's going to work and come back to me in a couple of years. And that's fine. So those were the four reasons. And I kept hearing one of those four reasons over and over again. And that has helped informed over the last 18 months how we're creating the whole ecosystem to develop each of those concerns to lower the barrier for doctors to enter. And so now we can address their Medicaid concerns. On-call concerns, we just have more data. The financial dip, we have some side gigs that will help people bridge, or we can help them if needed. And if they just don't think it will work yet, we can speak to the more than 100 pediatric DPC practices around the country that are succeeding. Some are succeeding, some are just growing. But as you know, the movement in peds is growing very quickly. It started out much slower than the adults and the family medicine docs, but now we have people joining every month the pediatric DPC field.
100 people, 100. And I'm sure that by the time that this airs, that is an old number, because when the Pediatric DPC Mastermind first started in February of 2023, there were 60 people in attendance. And then that grew by over 40 the next year by 2024. So stay tuned for West Coast Pediatric DPC Mastermind. Those are words from Dr. Deanna Berry's mouth herself. So stay tuned. Come visit me in Arnold, California. But the movement absolutely is growing because, yes, people have these concerns, but the people who have said, I'm going to do this, are taking those bulls by the horn of all of those doubts and all of those fears and saying, I'll deal with it because it's better than going back to fee-for-service medicine. So
Right.
I just love that for the people who continue to do DPC, you are showing, look, this is succeeding. Rural, urban, doesn't matter. You could literally can do this. You want to do nonprofit? Fantastic. You want to do micro practice? You want to be part of a network? Fantastic. It's all physician led. You can do it. So
as you know, we just completed a national survey for pediatric DPC. We have 79 respondents. We have a couple of medical students analyzing the data as we speak. They should finish this week, and then we hope to write a descriptive paper. But you're absolutely right. It's urban, it's rural, it's suburban. But those 79 responders, I think 50% of them are less than 2 years old in practice. So it's really young in the pediatric space. And we know there's more people doing it, but that's who responded. So we're excited to share that data. We're very excited. The fact that the movement is growing and we have at least 100 pediatric practice now is great. We have all these people coming to the pediatric DPC mastermind. And these are all people who have an entrepreneurial spirit, which is fantastic. They want to run their own companies. And Zest is really about lowering the barriers for people who want to join. What I always say is, if you're a DPC doctor, or if you're any pediatrician doctor, you already have 2 full-time jobs. You're a doctor and you're a parent. And those are full-time jobs. And all the more power to people who want another third full-time job of running their own business. But for those people who don't want a third full-time job of running their business, we are here to help support them still enter the direct care market. That's what we're all about. And building something bigger with the Zest Pediatric ecosystem, the Medicaid, our ZAPs, which are our professional assistants. And it's exciting.
Absolutely. So let me ask you, in terms of the 4 main things that you hear from pediatricians who are like, that's cool, I'll listen, but I have these concerns. One of those concerns that you mentioned is call, and very relevant to what you just spoke of, because I feel that in my bones, the whole like parent, doctor, mom, fill in the blank today, fill in the blank this hour. It always changes, right? Depending on what you have on your plate. And then when you add entrepreneurship and adding being a good business owner to it, there's a lot there. So call is a big thing that people are concerned about. They're definitely, and I will drop guidance here. If you do have 24/7 on your website, just proceed with caution, especially if you are a micro practice. For you guys, you are a network. And so you guys have the ability to spread call amongst people. And I know that especially in DPC, the adult world, that's always a challenge. People have the fear of, I can't take vacation. I'm a DPC doctor. I'm supposed to be able to take vacation, but I can't because I don't have anyone to cover. And that's not necessarily true. Definitely listen to Dr. Julie Gunther's initial episode where she talked about how hey, I'm out, go to the urgent care. I'm not going to be your doctor 24/7. But there definitely are people who feel that compulsion to be present or have somebody, another physician present who can cover. So can you talk to us about how call is handled in the Zest Pediatric Network?
Fundamental to any DPC is the relationship that the doctor and the patients have, and that a patient can access their doctor 24/7. And you do call it that, but nobody can be available 24/7. Patients appreciate that. and you need to set the guidelines with those patients. There's a lot of chat in the DPC groups about setting limits from your patients. We have a 2-page document we go over with patients before they sign up, and again after they sign up, about this is how you access the doctor, this is when it's appropriate, and this is what you do for each. It is really not that onerous. In a couple of weeks, we have 2 doctors going on vacation. I will be covering for them. I'm not that worried about it. Yes, I've lightened my schedule, but it's going to be okay. They know they're on vacation, so routine questions will wait from patients, and urgent things we will manage. So in our network, to answer your question, we each cover our own patients, but it is so simple for us to roll the phones to another doctor or the text to another doctor. Actually, I don't think we roll the text, but to roll the phones to another doctor, it's simple. So when people are on vacation, that's what happens. When people go to a concert, a show, that's what happens. People are going to the religious ceremonies, we cover for each other. It's not a problem. That's one of the reasons we wanted the network, is for coverage. That's also why we couldn't choose. I won't go into which EMR, but some EMRs refused, I'll say refused, to support a network. They only do one practice at a time. We wanted to cover for each other, which includes having access to each other's medical records. We wanted our support services to have access to the medical records. So we picked an EMR that would allow us to build a network. Anyhow, we cover for each other, and I've gotten a Pennsylvania license so that we can cover in that way, but it's so rare that you even need to call in a prescription across state lines. It's not that big of a deal.
And I think that, one, it's very smart that you guys, again, are physicians, and you know that setting boundaries, setting guardrails are important.
Yes.
Because if you are a person coming in, especially primary care doctors, like, we bend over backwards so much in our careers to help people out, even if we didn't get paid for it in fee-for-service, just because we knew it was the right thing to do. And so instead of taking advantage of that, doing DPC allows you to reflect on your experience, especially if you've been in fee-for-service, and say, what are you and are you not okay with? I definitely would say that, just a pro tip here, if you are working on setting boundaries for your own practice, I definitely would say that feeling of, I don't want to say no to my patients. No is a word, period. But also there's ChatGPT to help you out if you're like, please put this in the, I'm really trying to help you, but if you're not listening to me, that's really harming your own health and not mine, in the most PC way. Like, play around with prompts, because it really helps you envision what boundaries could be like in your practice. So just a free tech that you can use tip there. When it comes to the idea of the doctors having autonomy, covering their own call for the most part, I also want to point out here that, just like you're saying, it's not that when people join practices, definitely that's the most common time where they're like, does this really work? I'm going to call, I'm going to text, I'm going to do all the things. And then when they realize, you're like, oh, my doctor is actually on the other end of the line. That's pretty cool. All right, I know that they're there. And then they develop that confidence as patients in your practice. And so the trend is that they don't bother you 24/7, because they are also invested in the understanding. And if this is not apparent, I definitely would say redo your onboarding videos or emails to state, like, no, I am here for you. I am not okay with being called for Tylenol at 2:00 in the morning, when that is clearly not an acute thing. But setting those boundaries, Dr. Leah Gupta gave a great example of how she sets her boundaries with patients from the get-go, so that people understand, I got to take care of my doctor if I want my doctor to be there to take care of me. So I love that you guys have, again, the physician-led vision to be able to help each other out when needed, but also the vision to promote the autonomy.
Dr. Keeley tells the same story that you do, that patients at first just need to realize you're always there, then their anxiety goes down, they don't text you as often. And the other advantage of a network, well, there's many advantages of the network, but what you're pointing out is we've now opened 4 offices, 6 doctors have come on board. We have learned a lot of things in how to communicate with families and how to market, and we're always tweaking and revising everything, as is everybody else, I'm sure. But there's a lot to garner from that experience.
So now I want to go into another one of those fears, which is definitely something that I hear from pediatricians, but also especially from family medicine doctors who see kids still, is the Medicaid population, Medi-Cal in my case. lots of people believe that this is a concierge way of doing medicine, that you have to have a 7-figure salary to afford the model of DPC, which that is hashtag fake news in this appropriate, amazing election season. But also, when you have a doctor who is able to have the autonomy to set their pricing, to do pro bono memberships, to do the research,
and our data from the survey shows 70% of the respondents, I think, said that they have Medicaid patients.
Yeah, I definitely do. This is the marketing piece of it, but it's like when you really look at the nuts and bolts of how a person spends their health dollars, or how they don't spend their health dollars, as is very common with chronic pediatric diagnoses, and people don't seek care because it's too expensive, or one trip to the ER can be $2,000. And that's more expensive than 1 year of a DPC membership. I mean, this is where looking at other people's websites, how do people talk about DPC, especially in your field? I think it is very important. Keep your ears open all the time is what I would recommend, because you can always change your website, you change your copy, but helping people understand that you literally have a physician who's in your pocket, who knows you and who is accessible to you. And if that allows you to be more transparent with your healthcare dollar spend, rather than facing surprise bills or facing bills that are like absolutely ridiculous, like $60 for an ibuprofen tablet, a single tablet, then, this is where DPC is not concierge medicine. You do not need a 7-figure salary to afford a DPC doctor. So again, I think that's super powerful that you have, of the DPC practices, so many people participated, and that's the data that you found. I think it's also especially important for people to hear that. And then I encourage people to go back to your residencies, go back to your AAP meetings and say, DPC is actually very affordable. Yep. So with that, tell us about this collaboration with Medicaid, because this is fairly new as of this recording. There's news articles and news release about it. Tell us about how this even came to be, please.
So we're very excited about our relationship with AmeriHealth Caritas, Ohio, which is the Medicaid managed care plan that we're working with. I already told you that right from the get-go, a lot of doctors said, I really want to take care of my Medicaid patients. The other concern you hear from people like the AAP and other organization is DPC is going to increase inequities and disparities in healthcare. My partners and I wanted to address these concerns about DPC. It is not elitist, and it is not going to increase inequities. So right from the get-go, as we were planning this, I approached one of the Medicaid managed care plans. I happen to have a relationship because of my prior world in population health and working at the health systems. I had a relationship with the chief medical officer of Ohio. And we were talking about DPC. He said, I love this model. I love this concept. I'm so proud of you guys for going out and doing this. And we would have lunch every few months. And once we got launched, he said, why don't we think of doing this together? And I was like, let's do it. Let's do it. Let's gather the data to prove whether we can make the same impact in the Medicaid population as actuarial data shows is being made in Medicare and in the commercial world, right? There's plenty of data to show how much money is saved in Medicare and in commercial populations in the direct care model. There's lots of data to show how incredible the patient satisfaction is in Medicare and the commercial world, adults. There is no data in the pediatric space, none. So we wanted to gather the data. How better to do that than working with a Medicaid plan who gets actuarial data from all claims, right? All pay. So I was bringing in the population health work that I had done, and we decided to do this. It took 18 months. It was not simple. Both organizations had to get to know each other. We had to get comfortable with each other. We had to figure out what is a primary care cap. Managed care plans don't know how much they spend just on primary care. They know how much they spend on professional, facilities, pharmacy, durable medical equipment. They don't know how much they spend on anything that would be considered primary care. That took a long time to figure it out and to come to an agreement on what they would pay us on a monthly basis for primary care. So the arrangement is a value-based contract where we get a base PMPM per member per month payment, basically a membership fee. And then there's a bonus based on quality that is paid at the end of the year. And it's a very appropriate primary care cap for children. So we're eager to see if we can have the same results that the adults have had. Nobody's done this before that I know of, just in kids, Medicaid kids, and we need the data. I love data. That's the other reason we just submitted a paper yesterday on the value of telehealth modalities in pediatric DPC and how we know keeping kids out of the ER saves money. Our own patients have told us 70% of the respondents in our survey to our patients said they've stayed out of the ED, emergency department, because of this model. So we did a cost analysis, and you're absolutely right. Between avoided urgent care visits, ED visits, and all the office visits that normally would have copays, people pay for their membership plus. But again, there's no pediatric data. We are working as a network to create enough pediatric data to address the concerns about the cost, the elitist nature of DPC.
And again, I point out, if you have not, go back and listen to that episode with Dr. Garrison Bliss, Phil Askew, and Jay Keese, because this is where the history of DPC, the 30,000 Medicaid patients that Q Alliance was taking care of, and the lessons learned, and what you guys are bringing to the table and learning, it is important for us as physicians who are doing DPC to have a seat at the table. Just the year that we're recording this, the Medicaid Primary Care Improvement Act was proposed and passed unanimously on the House floor. And that was brought forth by a Democrat pediatrician, Dr. Kim Schreier, as well as Dan Crenshaw, Republican from Texas, because DPC is bipartisan. And when it comes to, can we prove that DPC saves money? Can we prove that access is better? Can we prove that there's better health outcomes? We're all like, of course we can. We've already done that. But in terms of the future of American healthcare, the lowering barriers for people to participate in DPC, the greater ability for patients to access DPC, and organizations like the AAP changing their mindset to say that this is an elitist way of doing medicine. This is where, again, it's if you have opinions, speak up. That's what I encourage people to do, because what you are doing as a DPC doctor is not a concierge doctor in terms of that 7-figure salary to access your care. And what you are doing as a DPC doctor is really, I know that I'm assuming that you agree with me on this, but it's really allowing people to love primary care again and to choose primary care again, which will help the access to primary care in the country problem that we're having. So on that, I will encourage people to check out the Medicaid Care Improvement Act. Don't know where it will go because we are in an election year, but in terms of speaking up, that is where I just, again, encourage people, go to Capitol Hill, share your stories. It's important. When it comes to the cost of care, it's crazy. You and Dr. Keely Mistovich were in on a Kevin MD podcast, as well as an article that you wrote. The kids are not okay. And one of the articles that you highlighted was an article really looking at chronic care in health for pediatrics, specifically asthma, epilepsy, diabetes, and the spend that goes into the care for those people because of poor access to quality care when they need it, poor follow-ups, delay of care, all of those things that we have been talking about. It's insane. I mean, like, we're talking, the study showed almost $1,380 to over $9,000 annually spent for children only 0 to 18 years with asthma, diabetes, and epilepsy compared to those kids without those conditions. So it's just crazy. And then the other thing that you didn't necessarily mention in terms of the things that pediatricians are concerned about, but one thing that was mentioned in this study, the average in this nation is 16 minutes that a pediatrician gets to spend on a preventative care visit. That is the under the floor reason for a lot of people burning out in pediatrics, and why a lot of people who are looking to do DPC love DPC, because I think that's also why they may tune their ears in. Wait, you're telling me I could spend time with my patients like I want to? That's amazing. What kind of practice is that? So can you speak to how you guys are able to work with the number of patients in your practice? Dr. Keely said she has 300 patients in her practice. What is the conversation that you guys have with the other doctors joining Zest Pediatrics to say, look, we are not the come one, come all. We are not the model where you're going to have, again, 2,000 to 4,000 patients. You're going to be expected to do all these things. How do you talk about the time in particular that DPC doctors are able to have through Zest Pediatrics?
Well, we explain to them that number one, your time is flexible. You get a much better work-life balance, and that most of the care, we don't know how much yet, we're trying to get the data, most of the care does not require an in-person visit. It is amazing. And in the fee-for-service world, you don't see them in person, you don't get paid. We keep people out of the office because you don't need to necessarily see everybody. They can send photos, everything. They can talk to you, they can do video conferencing, whatever you want. So the time is flexible. You can manage a panel of 300 people in a high-touch relationship. It's easy. The other soapbox I have is not only we can spend an hour on a well visit, but the entire idea of an annual well visit for a child is ludicrous, in my opinion. I haven't finished this blog yet. It's been half written for a year, I think. I need to finish it. The annual well visit has been created by insurance companies collaborating with the AAP. It's great. So we have guidelines and we get people in for an annual visit. It's free. The Affordable Care Act requires it to be paid. But to think that a kid only changes on their birthday is ludicrous. And just because they're fine on June 30th doesn't mean on September 15th, they haven't been bullied. They haven't started with an eating disorder. They haven't started pooping in their pants in school. It's ludicrous. And so you have to be able to do periodic check-ins when it's needed and get away from this fallacy of an annual checkup. But that's my newest soapbox. It's about a year old, but I am still perfecting my argument about why it's so ludicrous to have an annual well visit. It's a minimum. That's a minimum. And what a lousy bar that is. What a low bar that is for an annual checkup. Otherwise, don't come to me at all. I'll see you once a year. It's ridiculous.
So how do you encourage your patients to change their mindset when it comes to, oh yeah, it's time for my annual, and like, oh, we're fine. Oh, now we're sick. Like, how do you encourage people to instead use the DPC membership for, I have a question about this behavior. Is this normal? Like somebody said, this spot looks funny. How do you encourage people to remember that they have a doctor and to reach out to the doctor to build that relationship with them?
There's a couple ways to do that, and we're learning on this journey, as is everybody else, especially in peds. But you have to have proactive outreach to your patients and touch bases, which can all be automated and easy. And when you're working in the corporate health, you wait for them to come to you. There's not enough outreach going on, although more and more people are working on it. Many of the companies that I help consult are working on this automated outreach to families to keep them engaged. But one is outreach and touch points. And all this can be, as I said, automated. The second is we have a whole different kind of mindset in a holistic or a wraparound comprehensive approach. So within our network, and because we're a network, all of our patients have access to lactation consultants, sleep specialists, dietitians, parent coach, and psychologist now is our newest one. And so making offerings around these core services, which are so important to a child's trajectory and their happiness, keeping it forefront in the family's minds helps them to realize that we're here more than just for their skin knee, their bruises, their spots, and their colds. That we're here to help them succeed as parents. And in fact, if you look at our website, we are here to partner in parents in creating the healthiest, best lives for their children. It's not the healthiest lives for their children. It's the healthiest, best lives for their children. So it's comprehensive. And I think any DPC doctor, adult, peds, whomever, takes that more holistic, comprehensive approach. So many doctors now are getting extra certifications in lifestyle medicine. What does lifestyle medicine look for in pediatrics? This is what we're thinking of. It's sleep, it's diet, it's screen time, it's resiliency. It's all of these things that we have to do a better job of teaching them. It's not just about managing them when they get sick. It's not just about managing them once a year for their checkup and assuming they're fine for the next 12 months.
So important. And I think that that's also what helps build in patients understanding the value of the membership and to prevent churn going into the future.
Exactly.
And also
you have data on churn. At least for us, it's minimal. It doesn't exist unless they move
Yeah.
or somebody loses a job, and then we work with them. But what have you heard from other people that you've had on? Do you give a feel? Is there much churn in DPC?
So I think this also speaks to the word of mouth, that is the way that most practices grow, is the word of mouth as to what the care is like at a DPC practice. And it makes people really, just like the pediatricians who are interested in hearing about the model, other physicians who are interested, when patients hear like, what? You were what? They what? You didn't have to go to the ER. You didn't spend $2,000. I think in this world of social media and all the crazy that happens with the perfect life and the fallacy of that online, you truly have people who are out there who are so happy about your practice and they end up talking about it. There's doctors who have highlighted patients' social media platforms where they're like, so I just talked with my doctor and this is what we did. And we spent 40 minutes together. And I think that when they're so excited about my investment is it's priceless. Like it's an affordable investment, but I'm able to do this. I think that encourages this culture of very little churn when it comes to DPC, because when I've talked to other people, definitely the major reasons of churn have been open enrollment. That's one, but it's not the big one. But I think that's one of the most common around September time of year, but definitely moving, like that's in our practice, has been the number one reason why people are not our members any longer. And when it comes to what you just said, if somebody is unable to pay, there are people where it's great. Because we talk so much and because our visits are not 15 minutes, I know that your spouse experienced this and now you have all of these bills to pay. It's like, if I can help out and I'm still able to make overhead, but I'm able to be like, hey, let's work together. What can you pay? Like, why don't we pause your payment and we restart it? Let's just keep having this ongoing conversation. You're able to be that humanistic doctor, even when it comes to the financial investment that our patients are making. So I think that's great that you guys are seeing very little churn. It's not unexpected. Yes, Dr. Doug Farago has his book about churn and how to prevent it. But I see people having more talk about, how do I do this? How do I make a social post? How do I, not like, how do I make my patients understand that I really care about them or that this practice is for them? Like, it comes through just being a doctor and with the time to be a doctor. It's amazing. So now let me ask about your network, because again, you mentioned earlier that zestpeds.com is where you want to go, but definitely you guys have your list of zaps out. Drew, I'll let you describe that a little bit more, but I will do a shout out because when we talk about engagement, your guys' calendar is amazing. You have a way for a patient to access a calendar of all of the zaps that you offer, but also there's pictures in the calendar, which is what I thought was so cool, because then it's like you can scroll through and you can say, oh, this appointment is open for a prenatal or a lactation consultant. This one is available for this provider and that provider. So tell us about not only what zaps are in more detail, but also how did you establish that network?
Well, first, I'll give entire credit and call out to Keely Mistovich for managing the website, which is beautiful and wonderful. And yes, she's put pictures throughout it and came up with the ideas of the calendar. We had lots of discussions on the zaps and how to engage them. They're 3 or 4 months old now, and they're very popular, going very well. Again, Zest Additional Professional Services is ZAPS. Justin came up with the acronym ZAPS, which we love, another Z word. And one thing I learned when I left the health system and both started consulting, but more so when we established Zest, is that there are dozens of people in your community that are not part of a health system that want to support and help children. And some of them do it with insurance and some of them do it cash-based. But when I was at the health system, it was all about, we keep everything in the health system. We don't engage with people out in the community. And so all these people were hungry to work with pediatricians who are not part of a health system. So we developed an incredible network very quickly. Word spread that there are pediatricians doing something innovative, something that really supports relationships with patients again. And we just met all sorts of wonderful people. So we decided ZAPS. Why did we come up with the model? Again, with my population health background and Keely and Justin's desire to provide holistic support for families, We knew that every family deserves lactation and sleep, dietitians, psychologists, parent coaches, but how do you create it? In the adult Medicare world, there are many networks that have on-site pharmacists, social workers, dietitians, etc. And when you have Medicare patients and each doctor has a panel of 600 or 800, you can support a dietitian or social worker on site for that clinic. In pediatrics, where the panels are 300, that's our goal at Zest. And kids, although 30 to 50% of them, depending on Medicaid or commercial of chronic diseases, they all don't need those wraparound services. So a network allows a hub and spoke of these providers. So they're not even all in Cleveland necessarily or in Pittsburgh. A lot of this care could be done virtually. So we created the hub and spoke model for our Zest additional professional services. And now all of our members have access to these people virtually, and we're able to support multiple offices with a single specialist. That's how it came about. And we're very excited. And patients, the feedback's been incredible. Yeah, it's great. But thanks again for acknowledging the website. It was a journey, and it was difficult to figure out how we were going to make this happen. And now the challenge is, as we grow our classes, which we're very proud of, is how do we maintain the calendars? But we'll figure that out.
I think that that's so doable. And also the thing that came to mind when you were talking about this, what you guys are doing doesn't sound elitist to me. I'm just saying AAP, that does not sound elitist at all, that you are encouraging community involvement in the care of the community. So
continuity of care that they are providing, and they're all in the same EMR. So that's the argument of keeping everything in the systems. Yes.
Awesome. So let me ask you about the world of pricing, because definitely with you mentioning how most of the respondents on your survey were within their first couple of years, that definitely there's pediatric practices that are out farther than that. But for the most part, pricing in pediatric DPC is something that is a very hot topic. So tell us how you guys approached pricing at the Zest Pediatrics Network.
You have to remember that pediatrics is different than family medicine or internal medicine. And for the most part, pediatricians tend to see kids that are younger. Some of the family medicines that do kids also don't manage the vaccines and don't have as frequent visits as the babies. Most pediatricians do home visits. Most pediatric DPC doctors do home visits for many months. So it's a different model, and we've added lactation and sleep and dietitians. So we had to pay for all of this. We also have smaller panel sizes in pediatrics than in family medicine or adult. And that's because the younger kids need more frequent visits than the adults. And also because we all know parents of young children are more anxious. They care more about their kids' health than they do their own health, which is great. So we just believe in pediatrics that we have smaller panels. There are some that still have panels of 400 and 600, but for the most part, it's 200 to 300, some even less than 200 in a micro practice. So like everybody else, we figured out the pricing is, if we want to have our ZAPs, we want to be able to support 300 patients, yet we want to have a salary that is acceptable. How do we come up with our pricing? And we knew our overhead, we knew our ZAPs. That's how we came up with our pricing. So we believe in transparent pricing. It's on our website. We know not all DPC doctors believe that it should be on their websites. Pros and cons to each. We have them on our websites. We offer, again, different than the opposite of family medicine docs and internal medicine doctors. The younger the kid, the higher the price. Price goes down all the way up through college. And we give discounts for the second kid. We give discounts for the third kid at Zest. And then if they have 4 or more kids, we recommend they talk to the doctor, and we'll come up with a price that works for everybody. Because even that depends on, does your kid have chronic problems or not? And because obviously if you have an otherwise healthy kid, it's going to be a little less visits and less time consuming than if a child with medical complexity, which may need to have touch bases every 2 weeks or more frequently. So if it's more than 3 kids, we do pricing based between the doctor and the family. And again, it's done locally. The doctors locally decide what they're going to charge each family. We're not we're not telling them exactly how. We'll give them recommendations. They manage their own practice. Locally, they decide what procedures they're doing, everything else. We believe everybody needs vaccines. And so we help them set up vaccine solutions locally. But they pretty much decide how they're going to do it. They have to abide by AAP guidelines and the practice standards of care. But we really want doctors to have the autonomy of their own locations.
Fantastic. Thank you so much, Dr. Herz, for joining us today and sharing about the Zest Pediatrics Network. Definitely go to zestpeds.com to learn more.
Thank you for having me on. It's a lot of fun.
So that's a wrap for today's episode. We will be talking even more in depth about the Managed Medicaid plan at Zest Pediatrics Network. So be sure to join us for this conversation over on our Patreon community. Find the Patreon community at patreon.com/MyDPCStoryFan or in the show notes and on our website. Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.